So, very good morning to all of you, and thank you, Dr. Vishali, for having me here and as a part of the IC, and thank you, AIOS. So, what do we do when we see mass lesions in the choroid? And these are different clinical scenarios. So, you'll be seeing this slide often in my presentation. I'll be coming, so take it as a baseline slide. So, we have 5 different clinical scenarios of a mass lesion. And let's look at the first one where we have this solitary lesion in the posterior pole of the left eye. And all that we do is, after taking the clinical history and the examination, we resort to the first non-invasive imaging, that is the OCT. And at times, OCT is good enough to give us the clues. And here we can see a large bump from the choroid pushing the RPE and the neurosensory retina forward, with a good amount of subretinal fluid as well as fibrin. So here we are dealing with a choroidal granuloma, and clinically also you're seeing there isn't a lot of exudative response. So this was a choroidal granuloma, and we confirm our findings on the fluorescein angiography, which shows a lot of leakage along with the granuloma. So coming back to the basic slide again, we go to the second case scenario, where sometimes it's not easy to clinically say whether the lesion is in the choroid or above the choroid. And again, we do the OCT, where it tells us that the lesion is actually above the choroid. So the choroid is not involved. All that you're seeing is a hyperreflective response beneath the neurosensory retina, and there are no signs of inflammation. You go back to your clinical examination, you look at the history, there is a chronic progressive loss of vision in the eye, and we do the autofluorescence where we have the diagnosis written for us, which is a case of a chronic CSC presenting with a subretinal fibrin. And we confirm our diagnosis with the fluorescein angiography. And we just observe the patient, we take the relevant history, and we found this patient was on steroids. We asked the patient to discontinue this steroid. The patient was using some steroid cream for a skin allergy. And at 3 months, you can see the lesion disappearing altogether. And we confirm it on the OCT, it gets back to normal at 3 months. So coming back to another clinical scenario, we have a choroidal mass lesion. Now when we zoom this fundus picture, this is a young girl, 12-year-old, presenting with decreased vision in the left and the right eye for 2 months. Now, if you pay attention to the clinical examination alone, we see there are different levels of colors, different levels of pigmentation within the lesion, and the lesion extends much beyond than what it apparently looks like. So you have a hyperpigmentation at the top level of the lesion, you have a hypopigmentation at the middle level, and you have some amount of hemorrhage at the lower level. So what are we dealing with? So what comes to our mind is it an osteoma? So we do the OCT, a radial scan, to see all levels of the lesion. Here I would recommend a radial scan or a dense volume scan on the spectralis OCT, so that we cover all the levels of the lesion. And here we see the horizontal lamellar lines, the hyperreflectivity, the hyperreflective horizontal lines, the vascular channels, the subretinal fluid, all the lesions that corroborate with the diagnosis of a choroidal osteoma with a CNVM. We do the OCT angiography to look for the choroidal neovascular membrane. There it is. And the ultrasound again confirms now with the diagnosis of choroidal osteoma with a choroidal neovascular membrane. The combined fluorescein and ICG shows the typical features in the early and the late frames of the CNVM, more prominent on the fluorescein, and the osteoma more prominent on the ICG. So going back to this slide, we look at the fourth patient now. This is the wide field imaging showing a large mass lesion in the choroid. And this is the first non-imaging modality that we do, the autofluorescence. We do more widespread involvement than what we see clinically. However, we are not here again with the diagnosis. This is not enough. So we do another imaging. This is just to show the extent of the mass lesion. This is the top con imaging, and you can see the mass lesion is so vast, and so it's almost protruding anteriorly. The OCT shows there is subretinal fluid and a sudden elevation of the choroid, RPE, and neurosensory retina complex. We do the combined fluorescein and ICG angiography, and we see that there is a choroidal this was a case of choroidal melanoma, which was confirmed by typical appearance on the B scan USG. So coming to the last case, where the patient was symptomatic, we don't see much here, but we cannot ignore the complaints of the patient. And if you zoom this photograph, you see much more and more carefully clinically. There is a ring of subretinal fluid almost in the entire posterior pole. This is to show the extent. You can see there is fluid. The patient was symptomatic in the right eye. The left eye was normal. So we do the OCT and we see that there is an elevation of, again, a dome-shaped elevation with subretinal fluid. This imaging is on the top cone, and you can see the orangish reddish hue of the lesion, which was not very apparent on the optos imaging. The spectralis also shows this fluid, the elevation of the choroid, and you can see a lot of pigmentary changes in the posterior pole. So the ultrasound shows a very classical findings of solid mass hypoechogenic arising from the coats of the eyeball with high internal reflectivity. Autofluorescence shows the extent of the lesion, and here we are dealing with a diffuse choroidal hemangioma. We do the combined fluorescein ICG angiography and shows the findings of the choroidal hemangioma. So the key points, you have to have an algorithm when you see these patients of choroidal mass lesion, where most of the times the mass lesion is obvious, but sometimes it may not be. So we after a proper history and clinical clues, we do the imaging, which is of course has to be multimodal in these patients because we don't want to miss any finding. We start with the non-invasive with the OCT and go to the autofluorescence, OCT, angio, and ultrasound, and of course confirm our findings with the combined fluorescein and ICG angiography. Thank you very much.
Thank you. Thank you, Reema, for showing us the lovely cases and how to approach a mass in the choroid. So, any questions for Reema? Yes, Saurabh.
Very nice cases. In the osteoma case, how recalcitrant was it to anti-VEGF treatment? Because I've had a case, and in the absence of PDT, they have a tendency to recur. So, did you have recurrences
They
in the
have,
osteoma?
yeah. I think this was a young female. We injected once, but after that, the patient was lost to follow up. So the fluid went down drastically, but the patient was lost to follow up.
So, I've had a case in which I've injected 6 to 8 times
They
over 1
keep
year,
coming back.
and they keep coming
They
back in the
keep coming
absence of
back, and the
PDT.
problem is because this was a child. It was difficult to counsel the parents, and they were not ready to accept that the child needs injection in the eye.